the link on YouTube with your colleagues, and I'm sure they are going to enjoy the session as well. So please follow us on social media. This is very important for us and for you as well, so you can know what we are planning for the next few weeks, and you are not going to miss any of our activities. So this is our information on YouTube, on Instagram, and on Twitter. And I want to remind you that we are very happy to be a partner of the World Congress of Pediatric Cardiology and Cardiac Surgery. Please save the day for August and September 2023. It's going to be a very nice congress in Washington, DC. And we have a lot of nice activities planned for the next month. So we have Dr. Norman Silverman doing his very nice correlation of morphology and echocardiography. He's going to start a series about single ventricles. So it's very nice if you could join. We have Dr. Anderson making a new approach to his series. We are going to talk about sequential segmental analysis of the heart. Is going to be the next 2 sessions, maybe 3 sessions. We are deciding that. And then we have Diane Spicer, Dr. Adrian, and Dr. Justin showing interesting features on morphological pieces and 3D CT scans. It's very, very nice, this correlation. So please join us. And on Saturday, this Saturday, we are going to have this very interesting meeting from CCAS about heart failure. I invite all of you to join. And in February the 12th, we are happy to be a partner of Pittsburgh, Children's Hospital of Pittsburgh, and my dear friends, Dr. José Pedro Silva and Dr. Luciana Fonseca da Silva. We are going to have a very nice meeting about Epstein anomaly. It's the second one. Last year was very nice, and I'm sure this year is going to be amazing. So please join us. We sent an email to all of you today about this ECMO training course. It's our first online training course from ELSO. So this is very nice, and I'm happy to be on the board in this educational initiative. So we've made it in over 2 years with a lot of care. So I'm sure everybody who's interested in ECMO will benefit a lot from this training course. And we have the surgical training course as well. It's once a month. Now for end of January, we are going to have arterial switch operation. So it's a 3D printing training. So it's very nice. It's once a month. You can register and have more information. It's a very nice training course. And today with you, we are going to have our very nice fetal meeting. And we are very happy to have an amazing panel from all over the world, as usual, talking very interesting topics. So we are going to start with Dr. Yalda Afshar. She's going to talk about perinatal management of hypoplastic left heart syndrome, TGA, and heterotaxy. She is a maternal-fetal medicine physician scientist from the University of California, Los Angeles. She is the co-director of the UCLA cardio-obstetrics program, and her clinical and translational research focus is on the development of congenital heart disease that affects the fetus and the mother. So we are very happy to have her with us today. And please type all of your questions on the Q&A chat box. We are going to be very happy to answer in the end of the meeting. Thank you, guys.
Thank you so much for that warm introduction, and hello, good morning, good evening, good day to everyone who's here in many different shapes, sizes, and form. Thank you to the meeting organizers and my co-panelists for the invitation. I will take a different focus than what we usually do in this academy, is really coming to congenital heart disease from the perinatal perspective. So during the pregnancy, the prenatally diagnosed congenital heart disease, specifically, I'm not going to speak lesion specific, but more complex heart disease. How do we manage? How can we optimize the care for the mother? How can we optimize the neonatal outcome? And how can we continue to build collaboratively with our colleagues in cardiology, surgery, genetics to improve the care of all? So I have no disclosures, but just the disclaimer of my perspective as an obstetrician. And I'll go through some of the outline today is kind of who's in this team. And the fact that after the mother and the family really gets the diagnosis of this prenatally suspected heart disease, the rest of the pregnancy, how can we normalize it? How can we focus on the rest of the baby, genetic testing, counseling, antenatal testing, and then delivery planning? So I always start with a dedication and inspiration before any talk. This one specifically, Theo and Charlie, it's TET PA and PS, prenatally diagnosed monochorionic twins, spontaneous pregnancy. And the mom here really felt strongly about, her movement towards a vaginal birth, normalizing the pregnancy. And these kids are thriving and doing well. So they just turned 2 a couple months ago. So today's talk is for Theo and Charlie. So multidisciplinary approach to congenital heart disease. We focus a lot, and we should be focusing, and this group brings together content expertise in fetal echocardiogram, but really we have to remember the rest of the team in that pregnant woman's journey, in her family, and that includes the OB and the maternal fetal medicine doc, and obviously nursing, social work, genetics, the neonatologist, the CT surgeon. And I joke with our pediatric cardiologist at UCLA, their job is easy. I tell them that there's something wrong with the heart when they come to them, and we're doing the screening. And I say that very facetiously, but don't forget that every, pregnant patient generally gets that ultrasound screening test, right? That first evaluation, to look for anomalies. We're still not doing great. We're missing quite a lot, but so the screening originally happens with the OB or the maternal fetal medicine doc. And then after the heart diagnosis, in collaboration with pediatric cardiology, is, the rest of the body, the full assessment of extracardiac anomalies and an underlying genetic testing if indicated. So, pregnancy is normal, right? Pregnancy is a normal physiologic state, is the #1 reason, at least in the United States, that folks are hospitalized. And it's something completely natural. It's not disease. And it's always hard, for this person to enjoy the pregnancy and this whole idea of you're creating this human with this diagnosis. So a lot of the work we do is risk mitigation of, it's okay. Your VV ECMO unit, which I call it the placenta, the VV ECMO unit, really Mother Nature does it best, is an amazing way to grow this baby, grow it bigger. Normalizing birth and vaginal birth generally is safe. And just reminding the pregnant mom that you didn't do something that caused this. You didn't exercise too much. You didn't have an extra sip of alcohol. You didn't do anything that caused this directly, because the blame there. And that's a lot of normalizing the pregnancy. Okay, so we have a congenital heart, prenatally suspected, whatever it may be, complex in this case is going to be the focus. We have to look beyond the heart. And that's really our job, is that we know that after we have the diagnosis, and our pediatric cardiologist and many of you here are working to really look at the circuitry, the collaterals, is what else is going on with this fetus? What is the brain looking like? What is the perfusion there? The kidneys, what are the extremities, the neurodevelopment, brain, etc. And this is really, really important, because we know the fact is extracardiac abnormalities are there. The incidence of heart disease in the presence of more than one extracardiac malformation is 20 to 45. Obviously this is specific to the lesion and the system, but about 70% of GU abnormalities, there are some cardiac malformations. If there is, CDH, 30% the chance of a cardiac malformation. So with extracardiac malformations, we should be checking for cardiac malformations. And with cardiac malformations, we need to look beyond the heart at other things, because the importance here is, and in multiple series, they've kind of looked at what are the percentage of extracardiac anomalies associated with cardiac disease. And you can see a wide spectrum, single digits, all the way up to about 50%. And this really goes back to developmental biology, right? So, by really early on, the events of human development during the embryonic period of the first 8 weeks really is organogenesis. Most pregnant people don't even know they're pregnant at this time. The heart is completely developed, and I don't need to tell this group, but the rest of the organ systems are concomitantly developing. So the chance of something going on in the signaling mechanisms are there. And this is going to give us huge, huge clues to how we can better care for these pregnant people. So when we look at cardiac development, really, I know we say it's fetal in a lot of this, genotype intrauterine environment, but really embryonically in early development is where the vast amount of these actual changes are occurring. So baseline, all comers, the rate of congenital abnormalities are somewhere between 3 to 4%, right? So this is every single pregnant patient. We know that it's about 5% risk if you're 5 years old to be diagnosed with a genetic disorder. And that's just because many of them aren't manifested until later. They're not structural, but I am here to really kind of argue and to emphasize the importance of determining a precise diagnosis for these families when there is more than one organ systems, when there is complex heart disease, because it's going to help us, sure, intellectually and in the lab, understanding etiology is great. And, but it's not just intellectually, it's to help provide a prognosis for the family. It's to help provide the risk of recurrence if they want more family members to that fetus, to that baby that's born, to provide a risk of, passing it down. And so a lot of the construct here of genetically evaluating the fetus, and I'm not talking about screening, and we'll touch on that, but truly diagnosing genetically is helpful for their own health and to optimize their care. So genetic testing, really for in obstetrics, the focus of genetic testing for more than 30, almost 35 years has been Down syndrome. That's the focus of all prenatal screening programs, right? Serum analytes, the nuchal translucency test. We brought about now carrier testing, right, for autosomal recessive diseases. But really, this shift is occurring. We're moving outside of the fetal. We're not just talking about single aneuploidy, right? We're not just talking about trisomy 21, 13, 18, Turner's, but really single gene disorders. We're looking at more than that. And this can help these families optimize the care in a better way. So how can we do this prenatally, and how can we improve the care that these babies will receive in the NICU and the CT ICU, and then for their life? Okay, so invasive diagnostic testing, really, there's 3 arms, 3 tenets. It's, began quite like in the 60s. So amniotic fluid, classically amniocentesis, really safe. It got a bad rap, but it's, right now the risk of any issue is less than 1 in 1,000 in operator hands that are common. It's an ultrasound guided procedure. In essence, just take a little bit of urine from the baby, and then that's what you're going to use for downstream testing. What that it's not, I had an amnio, it was normal. I had an amnio and I decided to do a microarray. I did a karyotype. I did exome. I did a hypertrophy panel, whatever it may be. So that's what you're starting with. It's kind of like the blood draw, the amnio. Also, there's chorionic villus sampling, right? A placental biopsy. The caveat there is placental mosaicism, less than 1%. So you can, in essence, really just biopsy this early placenta. Again, an ultrasound guided procedure and very simple. So we have an amnio that's done around 15, 16 weeks, a CVS that could be done earlier, around 10, 11 weeks. And then even before that, for families that undergo IVF for whatever reason, be it infertility or for genetic reasons, there's PGT, which is prenatal genetic testing. And then what testing they do then obviously is dependent on what's needed. So the big game changer, it's now been a decade standard of care, is the microarray. So no longer is it just the karyotype, right? Counting chromosomes, but really huge substantial leap forward has been looking at chromosomal microarrays for copy number variants. Right now, this is the standard of care for 22q11, for example. We should be using, FISH for testing. Really, we should be using chromosomal microarray on those with lesions that we need. And we know that the yield is better here. And often now we're getting answers quite quickly. And there's no need, if this patient had a prenatal microarray, and there's a diagnosis, it doesn't necessarily need to be repeated postnatally. You can always, reanalyze or take a look. And the issue there is VUS, and again, beyond the scope of today. But standard of care should be a microarray in the setting of abnormality. So, I would be remiss if I didn't just bring back or kind of discuss the issue of cell-free DNA screening, okay? Everything we've talked about before has been a diagnostic test. So CVS, PGT, as well as an amnio, right? Because that's an actual biopsy sample. Cell-free DNA is amazing, right? This ability to isolate fragments of cell-free DNA in the maternal plasma that belong to the placenta, right? They're not fetal cells, they're placental cells. So very similar to what CVS is sampling. And what has been shown by Dennis Lowe and Diana Bianchi is really the ability to look at differential rates of aneuploidy, right? Aneuploidy, like T21, has a different signature compared to a normal chromosome count. And that's really been the premise. It was originally described in sex chromosome because, the XY versus XX. And this has been great. There's a lot of work now, including the SMART study that was just published, about looking at it for copy number variants like 22q11. The positive predictive value is not there. It is not there to be yield for diagnostic reasons, but nevertheless, we will eventually get there. And folks are doing clinical trials looking at this for single gene disorders and Mendelian disorders currently, but it's excellent for trisomy 21 as a screening test. But again, it is not diagnostic. So I think it is a little confusing when we see this in our prenatal hands, but just to be very clear about that, there are issues with it. It's fantastic, but vanishing twins, placental mosaicism, contamination, in the cases of, for example, maternal malignancy, transplant patients. So those are caveats to consider. And these are things that we can work collaboratively with OB. So again, my push really is that determining a prenatal diagnosis is key to optimize the care of this pregnant baby, this pregnant mom, and then her baby. So not every lesion has an underlying genetic etiology that we know of, right? We have not made the strides we had hoped for understanding the genetic mechanisms. And this is the nature-nurture duality and what we're doing in our laboratories every single day. With an AV septal defect, the chance there is 50 to 75% of an underlying aneuploidy. This is aneuploidy, okay? But for example, in things like heterotaxy, it's not related to the counts of the chromosome, right? May it be related to the chromatin and the cilia and, et cetera, but it is not aneuploidy. And so based on the underlying lesion, your a priori, what you're considering as the underlying mechanisms that led to this in development are different. So for example, when you think about 22q11 deletion, obviously there's a difference in cardiac defect, right? When you think about the arch, and I know we're going to have a talk later on the arch specifically, but you should consider 22q11 in this differential. And why is that important? Because it affects the thymus, it affects the electrolytes of the baby, and that's going to optimize the care right after delivery to improve the surgery if needed, to then improve the entire course. So knowing it is not, people oftentimes think about diagnostic testing as a decision to continue versus terminate a pregnancy, but no, it's really to optimize the care if they do decide to continue, right? So this is a really important caveat. And I think how I've really changed my counseling to push towards getting more detailed answers to optimize care. So genetic testing is important. And then we move towards the counseling of these pregnant women. And, you know, I feel very lucky that I am MFM, but I spend most of my time with the pediatric cardiologist and the adult cardiologist because we work together every single day. When we see these patients, we're counseling them together. And it's not that the cardiologist is saying, you know, you need to have a C-section really early. We need to get this baby out. You know, we've powwowed together. We've made a plan. We agree. And then we go into the patient's room, anticipatory guidance on the same page. And we coordinate, you know, her birth at a time that, you know, I make sure that I'm there. I make sure that the ECMO unit's ready if needed to be, and the cannulas are set. And it's really nice to be coordinated in the care of these complex patients. And those of us that are lucky to do deliveries at hospitals, the same hospital that the baby gets care at, really, I think it helps this communication quite a lot. So the counseling. And the counseling needs to be unified, right? Our job is each family makes their own decision about the complete pregnancy intention and, you know, the choices they have throughout the pregnancy, really based on what's important for them. My job is to provide them the evidence and the data, and then they make that decision because they're going to live with whatever decision they make for their pregnancy. And that is a team of obstetricians that includes high-risk physicians, family planning physicians, the general OB, the pediatricians, the pediatric surgeons, the social worker, the religious leaders if needed, whatever it may be. And so we provide this, and each family then makes their decision. But again, I will argue very strongly, these, you know, the counseling needs to be unified. This needs to be a rainbow that is really, really on the similar page. It can't be tangential. It's too much for a family to just hear the diagnosis and then hear different outcomes. I'm sorry, different stories. Okay. So we're going to stick to time here. Then what? So we have the diagnosis. The family decides to undergo genetic testing. They have a plan. And then how do we best care for these pregnant? So antenatal testing. And this is what I will say is really in close collaboration. We know, for example, left-sided lesions, right? The babies are often smaller. We see growth restriction, but this is not the fetal growth restriction, IUGR. We kind of use these terms interchangeably that we see in cases of placental dysfunction, infectious, right? Cardiac lesion with a smaller baby is truly like a cardiac etiology. We're trying to describe this a little bit better, but we know they're at risk. But is it safer to get that baby out at 37 weeks or let that, you know, the placenta, let it grow for a couple more weeks and get a bigger baby so it can come to the surgeon a bigger size? And I will argue the latter if there's good growth, right? Our ECMO unit, the placenta, does a better job today than our incubators do. And one day we'll get there, but we're not there quite yet. So in the setting of a good intrauterine environment, kind of growing the fetus as much prenatally, one that'll need immediate cath or immediate surgery, is oftentimes better. Again, these decisions are not made lightly and with collaboration with all of our colleagues. So what is, for example, the American College of Obstetricians and Gynecologists, actually the Royal College, similar guidelines. The goal of antenatal testing, you know, it's a little strange because the goal is really to prevent stillbirth. We know that having an anomaly is associated with stillbirth. They list a series of indications for fetal surveillance, but they don't specifically say anything about congenital heart disease or its anomalies. So we did a survey looking at how the University of California system, it's made up of 5 hospitals, San Francisco, Los Angeles, Irvine, San Diego, and Davis, how we manage our congenital heart disease. And I will say it's quite varied. The vast majority, 80%, do some kind of antenatal testing. When do we start it? Around 32 weeks. How often do we do it? Twice weekly. In 70% of the cases, and only 50% of the individuals did it because of truly cardiac disease or cardiac lesion. But the important point here is that, and maybe a problem, and this is something we're trying to explore more, is looking at, does the mode or so vaginal versus cesarean, or the timing of delivery change based on antenatal testing? And in 11% of the cases, it actually did. And so I'm going to kind of switch and think about why that's important, because we know we have to do serial growth scans. And I will say have to, especially in cases of left-sided lesions, because this is kind of our, we don't know how the brain perfusion is occurring. Prenatally, sure, we have these surrogates of MCA, but that's not really brain perfusion. We can't look at those white matter differences, but we can say, is the baby growing? And when we just look at cardiac output overall, vast majority of that is going to the placenta. Is there brain sparing? Is there not brain sparing? And these are kind of things we can use in counseling when we put it together, because we know even though it's talking about structural heart disease, there's more than meets the heart, right? We know that brain development is occurring concomitantly. And yes, this is easy to do in a newborn. We can do the MRs, but we're trying to push the boundaries of saying, how can we look at this prenatally, and how can we make these decisions to make sure that we're not keeping these babies in utero that maybe should be coming prenatally a little earlier. Okay. So we've been monitoring these babies, and now let's move towards delivery planning. So we know that prenatal diagnosis of heart disease is associated with lower birth weights, with earlier gestation of delivery, okay? And some of this is just true selection bias, right? This is some data from Shabnam Paivandi over from UCSF and the UC Consortium. And, maybe the lesion is more severe, maybe it's more obvious. Those are some caveats. But the issue is that both lower birth weights and earlier gestation have been linked to decreased survival and worse neurodevelopmental outcomes. So what can we do about this? And this is where I really am hoping to empower just simple QI intervention, a quality improvement intervention. So through our consortium, what we did in collaboration with, Anita Moon-Brady from UCSF, who was the pediatric cardiologist there, Mark Sklansky and Gary Sage from UCLA, and the rest of our collaborators. And we really pushed with our OBs, and we made sure the MFM and the cardiologist were, again, aligned in the counseling. We recommended delivery at 39 weeks. Term is 37 weeks, your due date is 40 weeks, right? And we know from a series of OB literature that really 39 weeks is probably the best time for moving towards delivery. And we show this. And so we recommended delivery after 39 weeks. We recommended vaginal birth unless there was routine obstetrical indication. The caveats here being complete heart block or some delivery coordination in centers for category 4 lesions. And really the other issue is prenatal counseling. So optimizing and recommending the prenatal testing. So these are the 3 things we recommended. Again, the data from the this is from the AHA document that talks about the category 4 lesions and the consideration for these that may need cesarean for coordination of care. Some centers don't need this, but just that's the caveat there. And what we showed is that we could actually decrease both the cesarean birth rate and early term delivery, early term being that 37 to 38 and 6 delivery, when we introduce this SCAMP. And this is really, really important just because it improves the outcomes, right? So not only were we able to achieve this, it actually improves the neonatal outcome. But I will say it takes work. Being on call for a vaginal birth of a nulliparous first-time mom, is like a 2-3 day process, trying to get her delivered during the day, coordinating with the cath lab. It takes a lot more resources and work. And obviously, coming in and doing a surgery is quick, fast, easy, but it has morbidity and it is associated with worse outcomes. So if we can optimize the care and move towards the vaginal birth, so be it. If we can get that baby to 39 weeks, obviously except for routine obstetrical indications for earlier delivery, and that's another improvement. And we show that, yes, in fact, we can do this. We can, even in a very high risk group, we can improve both the vaginal birth rate as well as the late term delivery. And the importance here and kind of the consideration I spend, my other hat is really taking care of moms with themselves have congenital heart disease. So, whenever there's a baby girl who is, being delivered, I think of, she's going to be my patient in no time if she goes on to get pregnant. So let's make sure she's healthy so she can then have a healthy pregnancy, because today there's actually more adults, and this is totally humbling, and something many of us have seen is these really severe cases of congenital, how many Fontan pregnancies I'm taking care of is humbling, right? This was considered a palliative procedure, and now I'm taking care of their second pregnancy. We know that they come out to be adults. Let's optimize the care. Let's get them a prenatal diagnosis. And the premise and how we can do this is really to making sure that each of these pregnancies are really, really optimized and coming to the pregnancy prepared, meaning that they come to us preconceptually. If they've had a previous baby with congenital heart disease, they come to us beforehand, us meaning all of us, and say, how can I optimize the care of the next pregnancy? Do we need to do genetic testing? Do we need to make sure they see maternal fetal medicine sooner? Whatever it may be. So we know in about 50% of pregnancies are unplanned. So optimizing that is definitely going to improve the outcome. So with that, I'm going to stay absolutely straight on time, and I'm happy to take any questions, thoughts, and we'll do that at the very end. So thank you so much for allowing a maternal fetal medicine doc who is in love with heart disease to your group.
Thank you very much. It was an amazing talk, very clear and very easy to understand. I'm happy that Dr. Rima was able to join us now, and Dr. Gil Vernovsky is with us today too. So I'm very happy to have all of you here today. Rima, please.
Thank you, Grace.
Hi,
thank you so much for taking over and really doing a very good introduction. And Yelda, I'm so grateful that you came. I know that you feel a little bit out of family, but really need MFMs and love to work with them. I have a few questions for you. I'm sorry, I was driving very fast and I wanted to catch the time. When you talked about detection and you were saying that we don't do screening or when we detect, this is the problem. Who is for the screening? And this is then we know that most of the congenital heart disease in fetal life are detected in the low risk patients. When do we come to a consensus which ones to screen, and where do we get the anomalies of the heart from your point of view?
Yeah, so I will say I'm thankful for many of the pediatric cardiologists that were loud and not complacent with the current maternal fetal medicine screening issues, right? The caveat being that, yeah, when many pregnant women come to care at a center with maternal fetal medicine docs and pediatric cardiologists, those are easy. But the vast majority of people are receiving care in more rural settings, right? There's a sonographer, someone else reading it, hundreds and hundreds of kilometers away. And so standardizing the bare minimum. So 4-chamber view, when Josh Capel and the group, established that now decades and decades ago, part of maternal fetal medicine screening, that was great. But we know what we're missing. Then the LVOT, the 3-vessel view. So that's Dr. Abu Hamid really has been pushing that. And now that is standard of care in maternal fetal medicine. So we're including that. Many of us are being loud about including cine clips, including color. And so it's always a balance of making sure that individuals have access to basic screening. But then if it's too much, we're going to lose a vast majority. Screening tests, it has to be prevalent enough of an issue, which congenital heart disease is, right? 1%. We have to be able to do something about it, which is send to a higher level of care, see a pediatric cardiologist. And then we have to have good enough techniques. And that's the caveat, right? If we make it too difficult, then we're going to miss the vast majority. So this balance will always be there. And I am thankful for those who are not complacent with the current status quo.
No, this was not my question. The screening is okay, 4-chamber and outflow, and the yield with the 4-chamber is about 60%, and if we do the outflow is 85 to 90. My question is that when are we doing the screen? Are we doing first trimester? Is this going to be the low for everybody? And who are we going to screen? Because the detection rate worldwide for congenital heart disease antenatally is not improving that much.
Yeah. So the issue of who to screen is those that have a little bit higher prevalence in the population. So I'm interested to hear what others are doing. For example, with IVF, we originally took off IVF as a part of the screeners, and SMFM, so Society of Maternal Fetal Medicine, just actually put it back in. So that went away for a year. And I think this will be debated. I would argue that we need to screen every single pregnant patient. 18 to 20 weeks at anatomy is like basic, but the issue is first trimester would be ideal, but people can't do transvaginal ultrasound in rural settings. People don't have the training. So that's ideal, but I don't think we're there yet as a society. I will say every single person needs a screening test. Those that need a pediatric cardiologist echo screening, is that your question, like a full echo screening versus a maternal fetal medicine screen? Because I separate those.
No, this is not the timing. This is because we always argue about the timing. Yeah. When are we going to do the screening? You put a standard of 18 to 20 weeks for an anomaly scan. But what we see nowadays is that we miss quite a lot of patients, and I think it's worldwide. Is there a way where you as obstetricians and MFMs help us, guide us to do the first trimester screen for maybe for everyone? Is this cost effective? Is this going to improve the yield?
Yeah. So I will say my total bias is that I do a first trimester anatomy ultrasound on every single patient that I see. But I know that takes a lot of time. It's actually not compensated. So our societies don't actually pay for that. They will, even the NT is not paid for oftentimes now that we have cell-free DNA. So I think that until we are able to get compensation for it, there's not going to be big shifts. Me and the cardiologist, they often come up to my suite when I do a transvaginal ultrasound in the first trimester because they can just see better and they're just not comfortable doing the transvaginal ultrasound. And so we're looking at the heart together. But that's like a 30-minute amount of time that no one's getting paid for. So that's the ugly reality. We do it because it's the right thing for the patient. But I think we need to be just really loud about making sure that this is, that we can try to do it. So I love it. I'm totally biased, but I don't think from a society public health perspective, that's feasible.
Thank you so much. Any questions from the panelists or from our audience? Yalda, you said something very nice about the ECMO, and Grace was introducing an ECMO course. So I think that's a nice thing to talk about when you're talking about placenta being the ECMO. Could you elaborate more on your ECMO versus our ECMO?
So unfortunately with COVID, I have gained quite a lot of expertise on pregnant people that I put on ECMO related to COVID. So that's a separate discussion, right? And hopefully that's the end of my ECMO training. But in terms of the fetus, truly, I know that we're trying to do the artificial placenta, but it is the way the implantation, the cannulation, it is the ECMO unit. It's not VA ECMO, right? But it's truly VV ECMO because that cardiac system is still there and we're interrogating the system. So I just think it's like the best example. And I hope that we continue to understand this amazing organ that's created just to maintain a pregnancy. And I think it's going to give us glimpses. And we're starting to, for congenital heart disease, understand how the placenta and the heart are developing together concomitantly to improve care. So one day our NICUs will have VV ECMO.
I've been to Dr. Bartley lab, experimental lab in Michigan, and I saw the artificial placenta, the research that they are doing there, and they have a good development. Anticoagulation and infection are the most difficult things to keep babies or now baby lambs on the artificial placenta on VV ECMO for months, but they're having nice results. I think maybe this is something very nice for the future of the preemies. Let's see.
I hope so.
Can we get Gil to talk a little bit about ECMO? What do you think of the placenta as an ECMO?
Thanks, Rima, for that relatively straightforward question. It's all, if I understand sort of where the discussion is where is the safest place to keep mom? And there's a lot of work where's the safest place to keep baby, whether it's in mom or early in the ICU? And in hearing what you all just said, I could not agree more that the best heart-lung machine is the baby's heart and the mom's placenta, period. So if that baby can be kept inside mom, that's the best way to go. If one of those is not working, mom's placenta or the baby's heart, then you have to take the baby out, and then you have to sort of deal with those issues. I like some of the stuff that Alan Flake and others are doing now with artificial placentas. I don't know if any of you have seen them. There's this great picture of a lamb in a bag, and I think they call it baby in a bag. So by the time the younger generation comes, we may have better answers to this. And I'm not sure, Rima, if I answered your question, but I couldn't agree more. And I know that the working group out there on the West Coast and those of us throughout the US anyway are so happy that people understand that 37 and 38 weeks are not term deliveries. 39 weeks and beyond is where you should, if at all possible, if no maternal indications, have a baby born with heart disease. Did that answer you?
If we talk that the placenta is an ECMO, so if you have an ECMO circuit, what is in and what is out? And if we try to make it simple for us, I mean, you deal with ECMOs as in intensivist most of the time. So if you look at the placenta more in details, which is the circuit exactly, or this is just being nice and talking, saying that, oh, the placenta is an ECMO. Because in your ECMO circuit, you have to have in, out, whatever connections you have. Is it? Because this is very important in future cardiac surgery for fetuses. If the placenta is the ECMO, then that would be great to utilize it.
Well, you know, something happened to my connection here. I apologize. There we go. It is, you know, the MO part, the membrane oxygenation part is real, right? There's a placenta with gas exchange. The EC part is the baby is out of the heart, right? Baby's is not attached to the placenta, but the key differences are there's not a centrifugal pump. So that's the baby's pump. That has to work. There's no anticoagulation, so that's good. So there's much less risk of thrombus. So all those circuits that are all the connections of and interfaces between baby blood and plastic go away. So in my mind, the placenta is better than any ECMO circuit for efficient gas exchange. The problem is getting blood, and that's what Yalda was saying before, that there are cardiac causes here with congenital heart disease. If you're, there it is, good. If your combined cardiac output is not going to get enough blood to the placenta, you will have growth restriction. So in my view, the ECMO part, ECMO, extracorporeal, yes, membrane oxygenation is the placenta. But what we deal with in ECMO also has a pump and an anticoagulation strategy, which is very, very different.
So
Grace, I'm talking, but Grace is the real expert on ECMO here, being key in the ELSO Society. I mean, what are your thoughts, Grace?
No, I think you're absolutely right. And specifically talking about usage of ECMO for tiny babies when the being inside the mom is not safe for the baby anymore. We are not there yet, but I think it's going to be something we are going to really use in the future. Rima, just to let you know that Dr. Karim will have to leave soon, so maybe he could be the next speaker.
Please introduce him. I'm very glad you're taking over. Thank you, Grace. Yes.
No, sorry for that. So now we're going to have a nice talk from Dr. Karim Diab. He is the director of the fetal cardiology at Innova Children's Hospital in Virginia and editor-in-chief of Pediatric Cardiology Journal. And he was a former colleague here in Doha, and he's truly missed here. He did a great job, and we really miss working with him.
It was a terrific recruit for the DC area. Terrific recruit to the DC area.
Good to see you, Gil. I hope you're not post-call with this. Thank you, Rima, as well, for inviting me. That's really great. I love this series as well. So hopefully with the time limit, we'll get through this. So I was asked to take a look at fetal coarctation and when to worry or not to worry about the fetal aortic arch. Hopefully all the videos will work here. So let's see. I think Yalda was a little bit lucky enough to have a lot of videos in her presentation. No significant disclosures for me to make. So the objectives of the talk would be to go over the basic views for evaluating the fetal aortic arch, Of course, know the basics of the anatomic presence of coarctation and the demographics of fetal coarctation, and mainly focus on the hints by echocardiography for when to suspect fetal coarctation and what are the predictors for when to suspect coarctation in the fetus. And we'll go over a bunch of examples that hopefully would be helpful, especially for those involved in scanning fetal hearts. So just to start off, the normal fetal arch, how do we scan it? We have mainly two views, the long axis view, or what we call the candy cane view, and the transverse view of the thorax, kind of like a modified three-vessel view, and we'll go over those in detail. So the long axis view, as you can see, we get the candy cane view of the aortic arch by 2D and color, and very important to really show the brachiocephalic vessels coming off, and important not to confuse that with the ductal aortic arch, which basically connects the MPA to the aorta. Many times you can really think that you're looking at the actual aortic arch when you're not. So important to really open up the brachiocephalic vessels and see the full length of the aortic arch when possible. Of course, sometimes it's very tricky in fetuses depending on how the fetal lie is. The transverse view, kind of modified three-vessel view of the fetus. And here you can see basically the ascending aorta and descending aorta. You can see here the trachea and the relationship with the SPC. And important to do this with 2D and color to look for any reversal of flow in the aorta as well. And in addition to this modified, what we call three-vessel view, is the actual three-vessel view as well. And obviously, this gives you a view of the main pulmonary artery, which is most anterior, the aorta in the middle, and the SPC. And typically, usually, the main pulmonary artery is slightly bigger than the aorta, which is bigger than the SPC, as seen in the cartoon as well. So these are the main views that we rely on for looking subjectively at the aortic arch. Now, what are the measurements that we look at when we're, really looking in detail at the aortic arch? Three main views: the long axis view of the aortic arch. From there, you can measure the ascending aorta, the aortic isthmus, and the distance between the left common carotid and the left subclavian artery, if you have a nice view of the aortic arch. The 5-chamber view to look at the ascending aorta diameter, and the three-vessel view to look at three things again: the ascending aorta, the aortic isthmus, and the ductus arteriosus. And in addition to the 2D, of course, it's important to put color, make sure that there is no reversal of flow, and do pulse wave Doppler of the structures. Here's another example just to show how we measure the ascending aorta just above the aortic valve in the 5-chamber view of the heart, and from the modified three-vessel view to look at the ascending aorta as well and the descending aorta. So what are the fetal aortic arch abnormalities? Of course, there are several. Coarctation, one of them, interrupted aortic arch, vascular rings, aortic tortuosity syndrome, and topsy-turvy hearts, more prevalent where Rima and Grace are, more than really in America. Here, for the sake of this talk, we're going to focus mainly on coarctation of the aorta. So what, just a quick demographics about coarctation. It's a relatively common lesion, happens in about 0.6 in 1,000 live birth, about 8% of all critical congenital heart disease lesions. And fetal diagnosis, unfortunately, is very tricky. It's still the most common ductal-dependent lesion that is missed. On the other hand, it has a high false positive rate of diagnosis. And the reason, obviously, we're always concerned not to undercall it because of its significant impact on the postnatal outcome of babies. So again, it's the most challenging form of ductal-dependent lesion to be diagnosed prenatally for us as fetal cardiologists. It has a very poor prenatal detection rate, and I'll go over some of the data to highlight that. And why is it important? Of course, because if it is suspected or diagnosed prenatally, then it impacts the management of the baby postnatally with timely infusion of prostaglandin and eventually surgical repair. Now, the institution of postnatal pulse oximetry screening, of course, has helped with improving some of the early detection, though again postnatally. So just a couple of papers just to highlight what the prenatal detection rate has been. This a study from Quartermain, mainly from the US, encompassing about 19 centers with over 30,000 cases of congenital heart disease lesions. And you can see here that the prenatal detection rate of aortic arch obstruction is less than a quarter, so really very low detection rate. Even when there is a PSD, we're still talking about less of a third of the cases being diagnosed prenatally. So really striking numbers when we look at the how good we are at diagnosing these conditions. This is a more international study, again, since there's people from everywhere attending this. So if you think it's done better in other countries, not really. I think that the major highlight from this paper came out just a couple of years ago. Over 18,000 cases. They included some centers in the US, but mostly Europe, South America, and a few again in the US. But the best center probably again in France, where they have a very solid and drastic prenatal detection program. Most of their interrupted aortic arch lesions were detected very high, I would say, for coarctation, even 2/3 of the cases were detected. But in the vast majority of the other countries, we're talking about less than 50%, and most of the time it's in the range of 20 to 30% at best, especially in the US, as well as I shared in the previous slide. So why are we not doing as well? Well, if we look back at why coarctation develops, there are historically two things that we look at when we're looking at coarctation, what we call preductal coarctation, whereby there is a diffusely hypoplastic aortic arch, and this tends to be a little bit easier to recognize in the fetus, and what we call the juxtaductal coarctation. This is more related to the ductus closing and causing some narrowing in the aortic arch, and those tend to be a little bit trickier to diagnose prenatally. So again, two theories, one for the development of coarctation, one related mostly to the ductal tissue causing the narrowing in the aortic arch as the ductus is constricting. This has been even hypothesized back in the 1855 by Skoda. And again, related to some intimal thickening and impaired elastic fiber formation in the aortic arch. Even recently, there has been a paper just looking at the degree of expression of prostaglandin receptors in the wall of the aorta in patients who develop coarctation versus those who don't, and it shows very higher expression of prostaglandin receptor in patients who develop coarctation. The second theory obviously is more related to hemodynamic changes in the fetus and how the blood flow pattern takes place for any reason whereby there is decreased compliance in the left ventricle. And obviously Rudolph has published a lot on that in the LAMB. So where there is decrease in the right to left shunting across the atrial patent foraminal valley, results in some decrease in the filling of the left ventricle, and this obviously leads to less than normal cardiac output that the left ventricle is handling, and lower cardiac output that is crossing the aorta, and eventually lower cardiac output that is being handled by the aortic isthmus compared to the normal circulation, and this eventually leads to hypoplasia of the left-sided structures, including the aortic arch, and potentially can lead to the presence of hypoplasia of the aortic arch and coarctation. Now, of course, there are several cardiac lesions that can be associated with coarctation, and of course, when these are present, it makes it a bit easier for us to recognize the presence of coarctation, just because those can be at times easier to recognize on ultrasound. So these can include aortic valve pathology. Of course, bicuspid aortic valve is very difficult to diagnose in the fetus, but hypoplasia of the aortic valve is a significant clue for the presence of coarctation, mitral valve pathology, whether it's hypoplastic or stenotic, the presence of the VSD, always, important to look at the outflows and assess the aortic arch, and complex congenital heart disease lesions like dwarf or any others, of course, then we pay more attention to the arch itself. Just like Yalda also shared, there's important, significant associated chromosomal abnormalities and various congenital heart disease lesions. So that's really, it's important to have genetic counseling and testing in these cases. Up to a third of these cases, including Turner, trisomies, and the George, can be associated with aortic arch obstruction. In addition, even a recent study looking at structural pathology in congenital heart disease lesions in the fetus, up to about a third that can affect other organs as well. So back to what really concerns us as fetal imaging practitioners, I should say, let's focus on the fetal echo features. Well, unlike the postnatal echoes, where typically you see some narrowing in the aortic arch and typically a shelf in the aortic arch with some very abnormal gradient across the aortic arch. Well, this does not typically happen in the fetus, and you really have to look for other clues, not only in the arch, but outside the arch itself. So just to summarize a little bit, some of the major views that we rely on when we're suspecting some arch abnormality, we look at the four-chamber view. Some of the clues would be discrepancies between the right and left-sided structures and their sizes, whether the ventricles or the AV valves. The five-chamber view, typically we look at the size of the aortic valve and the ascending aorta. The three-vessel view, of course, is very important, looking at the size of the ascending aorta, but also comparing the main pulmonary artery to the aortic ascending aorta or transverse arch diameters, and the longitudinal or the long axis view of the aortic arch to look at any hypoplasia of the aortic arch segments, specifically of the aortic arch isthmus, and the presence or no presence of a posterior shelf across the aortic arch. Of course, all that being said, many times, it's not very easy to image all these structures, and that's why it's important to get a measurements of various structures to really be able to make a decision. Doppler is important, of course. Looking at the aortic isthmus, you can see here possibly a small posterior shelf, and important to use pulse wave Doppler to look for any diastolic flow through the aortic arch, and of course look at the atrial septum as well, and the more severe forms like here where you see some reversal of flow across the atrial septum, and the more severe forms of aortic arch obstruction, typically those that are potentially leading to hypoplastic left heart syndrome. So the first thing that really gets our attention when we're looking at the fetal cardiac imaging is when we see right and left-sided discrepancies. The RV can look a little bit bigger than the left ventricle, the tricuspid valve slightly bigger than the mitral valve to various degrees. The three-vessel view can be very abnormal with the main pulmonary artery much bigger than the aorta, as is seen in this picture. However, it's always, then we look at the arch and decide if the arch is normal or it's not normal. And of course, it's very easy for everybody to look at the each side of the spectrum and see the very normal ones and the very abnormal ones. The problem is where we are in the middle gray zone. And one famous French Cuban artist once said, we do not see things as they are, we see them as we are. And so we always tend to kind of look at things and say, oh no, it does look normal. Or if you want to make it really abnormal, then you try to make it smaller and try to change your measurements a little bit. So that's why it's very important to look at objective data to really be able to tell in those controversial cases, is the arch normal or is it really abnormal? As obviously a lot of people started looking at various measurements that can be more objective to be able to tell if you really need to suspect coarctation and that particular fetus or not. So we'll go over some of the studies, and this really started several years ago, way back in the mid-90s. Norm Silverman and Lisa Hornberger published about a series of fetuses that they looked at retrospectively and looked at the discrepancy between the right and left-sided structures. And interestingly, it was obviously very striking. There was 60 to 90% discrepancy in the size of the right and left ventricles and the MPA versus the aorta. The most striking feature for detecting coarctation were mainly the presence of aortic arch hypoplasia. Again, those tend to be in the more easier cases, and the presence of a posterior shelf. Again, not very commonly seen in the borderline cases. And again, Lisa followed up on that and did additional cases to look at how sensitive this is. And however, the predictive value of the discrepancy between the right and left ventricles actually was not really that helpful. It was only 33% in general, and it was only about a little bit more helpful if it was done after 34 weeks of gestation, if this discrepancy is still present. And so people started looking more into exact measurements to see, how much of a discrepancy is significant. This came out from CHOP in the UK, and they found that the most important really measurement was the diameter of the transverse aortic arch, measuring less than 3 millimeters, and the presence of abnormal shunting across the atrial septum to really suspect coarctation in the fetus. So again, the type of measurements that we do, we measure the tricuspid valve and compare it to the mitral valve, the mid cavity of the right ventricle and the left ventricle, and compare those together as well. And we compare the pulmonary artery to the aorta in the 3-vessel view. And as you can see, various ratios can help you determine whether this is really significant or not. So from that study, again, what was a little bit helpful is that the numbers were a little bit similar for the various structures. So any ratio that is less than 0.6 was significantly associated with coarctation with a reasonable sensitivity and specificity. But the most striking ones for severe coarctation were the presence of transverse arch that is less than 3 millimeters in size, and of course, if there is a reversal of flow across the atrial septum. A few more studies just to look at that further. The same group with Jack Rychik from CHOP looked at third trimester fetuses, and again compared those with coarctation versus no coarctation, and looking at the pulmonary artery to aortic ratio. And a cutoff value of 1.6 was found to be significant, which again corresponds to about less than 0.625. So again, it seems the 6 number is really the key element. This study came from Spain. What is interesting, they looked at fetuses before 28 weeks and those after 28 weeks, and they came up with their cutoff values. And those that were associated with coarctation included a ascending aorta Z-score of less than -1.5, a pulmonary valve to aortic valve ratio of more than 1.6, again corresponds to the aorta to pulmonary artery ratio of less than 0.625, and an aortic isthmus Z-score of less than -2. Similarly, Anita from UCSF published this a few years back, looking at the larger number of fetuses with possible coarctation, and again looking at these measurements, and again strikingly the same numbers that were significantly associated with coarctation is a aorta to pulmonary artery less than 0.65 ratio, and as well the size of the aortic isthmus was found to be of importance as well. This is from Helena Gardner, again, a few years back. One important one from this study is looking at the 3-vessel view and not only comparing the ascending aorta to the pulmonary artery ratio, but they also looked at the aortic isthmus and compared that to the ductus diameter. And a ratio of less than 0.74 was found to be always associated with coarctation. So again, just really to highlight a few of the numbers that we rely on for looking at aortic arch obstruction or narrowing. Here's a nice study. I really like this one from Mark. You'll obviously work with him closely. I really like it because it highlights one major value, looking at the ascending aorta z-score, and if that is less than -2 z-score, then that's really suggestive of possible coarctation, or at least suspicious. And the ascending aorta is reasonably easy to scan compared to scanning the full aortic arch length in some of the fetuses. Now, why are these not enough? What are the limitations of looking at right and left-sided structures? Well, there could be other reasons and differential diagnosis for that, and we'll talk briefly about it. There are various cutoff values as are presented, although some of them overlap with one another, and they do change slightly with advanced gestational age. So there are different reasons why the right and left sides of the heart can be of different sizes. It could be left ventricular diastolic dysfunction, just to give some examples: restrictive atrial shunting, some forms of total veins, left SVC, and Jack Rychik published a nice paper on that. The constriction of the ductus arteriosus can result in dilatation of the right side compared to the left side. This is the paper from Chop, again looking at fetuses with persistent left SVC, whereby the structure ratios change between the second and third trimester, so not always associated with real full-blown coarctation. So people started looking for new measurements to try to even improve the detection rate of prenatal diagnosis of coarctation. This group from Seattle Children looked at 3 new measurements, including the distance between the left common carotid and the left subclavian artery, and interestingly, an angle, improvised angle between the ascending and descending aorta. I'll leave that to you. I'm not going to go into details of it. It's a little bit tricky and obviously it's more time consuming to draw the angle and really detect it. And it came off with their own cutoff values for various, measurements that helped predict the presence of coarctation in the neonate. A more recent study just published last year from Sweden, a retrospective study, including about 65 fetuses. What is interesting about this one, I think, well, they came up with 2 values. One is the index between the carotid and the subclavian arteries, very high sensitivity and specificity, although I think it's really tricky to see these structures in the fetus, and especially if you have very difficult aortic arch views. But what is interesting from this study is they came up with an equation to multiply the isthmus over the ductal diameter ratio and multiply that by the mitral valve to tricuspid valve ratio. And a cutoff value of 0.37 was 100% sensitive for coarctation and quite highly specific for the presence of coarctation postnatal. So that being said, with all these values, I thought we'll go over a few examples just to highlight how we use these. And again, I'll go over some of the striking, extreme end of the spectrum. This is a case of hypoplastic left heart syndrome with EFE. You can see the left side very small, reversed flow across the atrial septum. I know Shane will talk a little bit more about hypoplastic stuff, but again, this you can see the arch is severely hypoplastic, and by color you can see some reversal of flow in the aortic arch. So this is obviously very clear to most people who do some fetal imaging. Similarly, in the 3-vessel view, you can see the abnormality with the MPA being much bigger than the aorta compared to the normal, and some reversal of flow in the ascending aorta as well. So obviously this becomes very easy to recognize. Another, just to highlight some of the easier cases to recognize these, this is a fetus at 30 weeks. You can see a large VSD here, and you can see the great arteries probably better from this view. From the long axis view of the heart, you can see the pulmonary artery and the aorta, which is much smaller. And again, you really should suspect the presence of coarctation. You can see here part of the aortic arch, at least that looks very hypoplastic throughout. So these are kind of more the easier cases to recognize. Let's go back to some of the trickier cases. So again, to start off with a 4-chamber view where you see some discrepancy between the right and left side. This is a fetus at 24 weeks. Again, look at the short axis view. The right side really looked much bigger than the left side, strikingly smaller. And then we followed this fetus up and looked at the aortic arch. We saw that the MPA was significantly much bigger than the aorta, and compare that to the normal, so you can really appreciate the difference in size. And sure enough, the aortic arch itself was much smaller, and again with a diffuse hypoplasia and some abnormal flow by color Doppler as well. This baby had coarctation, of course, with hypoplastic aortic arch. Here's another example, a smaller fetus at 22 weeks. Was already diagnosed with amniocentesis with Turner syndrome. Again, look at the 4-chamber view, and we do the measurements just to highlight these measurements that we talked about earlier. So mitral valve to tricuspid valve ratio was just close to what the cutoff has been seen in various studies, just slightly below 0.6. The ascending aorta compared to the main pulmonary artery, slightly again abnormal. We're literally at the cutoff value of 0.6, and the ascending aorta z-score was minus 2.5. So that was a little bit actually more concerning. And the arch view, although was really difficult in this fetus, but really looked a little bit constricted. And this baby had a coarctation. Here's another fetus at 31 weeks. So again, starting off with a 4-chamber view, and you can see here just slightly larger right side compared to the left side, but really not that abnormal. Mitral valve to tricuspid ratio was actually within the normal limit, 0.87, so above the cutoff value of 0.6. And we went to the 3-vessel view, and you can see here the main pulmonary artery being much larger than the aorta. The ratio was abnormal, 0.44, and the ascending aorta z-score was minus 2.3. And this baby had actual coarctation as well. Looked at the arch. This looked also very narrow. Again, it wasn't very easy to image, but with all these values, we really thought this baby would have coarctation, and sure, actually did. Here's another fetus at 34 weeks. Just give a couple of more examples. The left side compared to the right side. Mitral valve tricuspid valve ratios were within normal. The ascending aorta to pulmonary artery was within normal. The arch view was not very easy to see, but was a little bit suspicious. The ascending aorta z-score was normal, and the baby actually ended up not having coarctation. Here's a fetus that was referred really late in gestation at 38 weeks. And you can see here in the 4-chamber view how much larger the right ventricle compared to the left ventricle is. The mitral valve to tricuspid ratio actually was quite abnormal at 0.53. We thought this baby will really have coarctation. Looked at the 3-vessel view. Again, you can see the difference in diameter between the ascending aorta and the main pulmonary artery. The ratio was again abnormal. The ascending aorta z-score was probably a little bit more borderline at -2. And in this case, we looked at the arch itself. We actually were able to see the arch reasonably well. This is kind of continuation of the ductus, but we thought maybe there is a posterior shelf. The pulse wave Doppler was a little bit abnormal with some persistence of diastolic flow. Here you can see the short axis view, much really enlarged right ventricle compared to the left ventricle. And this baby was born actually, the ductus closed and did not have coarctation. Here's a case actually that Grace was involved in, and we published last year. Not really coarctation, but it's really very rare case of what we call topsy-turvy heart with very elongated aortic arch, with the heart being really rotated. You can see the arch vessels are very elongated and diffusely thin. This is the SCT postnatally, just really very abnormal. And these babies usually have significant airway obstruction and narrowing as well. So from these, cases and the data that I've shared, I think really what I tried to do is summarize some of the key predictors and measurements that we can use to try to predict coarctation, or at least suspected fetus. The 4-chamber view is very helpful. Look at the mitral valve to tricuspid valve ratio, LV to RV, mid-cavity ratio. And the 5-chamber view, really helpful and it's very easy, usually in most fetuses to get, especially if you're having trouble visualizing the aortic arch. A Z-score of -2 is suspicious. The sagittal view of the arch, look at the ascending aorta and the transverse arch and the presence of a shelf. And the 3-vessel view, look at the aorta to pulmonary artery ratio of less than 0.6, the aortic isthmus Z-score less than -2. Again, I think it's interesting if you're able to measure the ductus and the isthmus diameters and get the ratio. If you have a ratio less than 0.74, this is suspicious as well. If you love math, I think it would be interesting to see if we can really validate further this equation from the group in Sweden. And multiply the isthmus to ductal ratio and multiply that by the mitral valve to tricuspid valve. And if the ratio is less than 0.37, then that has a very high sensitivity and specificity for coarctation. I modified this diagram from the paper from Quatermain. Whenever we're suspecting fetal right-sided versus left-sided discrepancy, or if you really are just unable to get any reasonable aortic arch views. So when this happens, we try to get these measurements, the mitral valve, tricuspid valve, aortic, aorta to pulmonary artery, and the aorta and ascending aorta and aortic isthmus Z-scores. And of course, look at the shunting across the arch and the atrial shunt. If those are normal, then we usually just recommend postnatal screening and then decide whether the baby needs an echo or not. If these are abnormal, at any gestational age. So again, just to make it easy, any ratio less than 0.6, an aortic ascending aorta Z-score of -2 or isthmus less than -2, or if you have any abnormal flow across the atrial shunt or across the arch, then we follow these fetuses at least every 4 weeks till after 30 weeks. If these persist, then we admit the baby postnatally to the NICU and start prostins and do an echocardiogram immediately after birth. And if these normalize afterwards, I think it would still be important to get the postnatal echo. However, we do not start prostins or admit to the NICU. So in summary, I think just when evaluating the aortic arch, there are 2 basic views, the long axis view of the arch and the transverse view. Suspected when the size of the pulmonary artery or aorta is abnormal for the 3-vessel view. If your Z-score for the ascending aorta or aortic isthmus is abnormal, it's very important to highlight really serial assessments in these fetuses to really to see whether the measurements really normalize with increased gestational age or not. And when the suspicion remains, of course, it's important to assess these babies postnatally. I'm not going to talk about interrupted aortic arch, but just thought to mention that these discrepancies are not really associated with interrupted aortic arch, unlike in coarctation, but that'll be the subject of hopefully future talk. So with that, I think hopefully I wasn't too late on timing, and I'll see if we have some time for questions.
Thank you so much, Karim. Thank you so much. Beautiful talk as usual, very concentrated. We will not have questions now because Shane will have to go as well. So if you, I know that you have a patient very soon, but if you bear with us for a few minutes until Shane finishes her talk. If you'd allow me to introduce our last speaker, but our not least, very important, Shane Morris. Shane is the Associate Professor, Pediatric Cardiology, and the Medical Director, Cardiovascular Genetics, Medical Director of Fetal Cardiology, Texas Children's Hospital's Baylor College of Medicine. Shane, you're most welcome. Please, you have the floor to talk. Thank you.
Okay, thank you guys so much for the opportunity to speak today. And this is going to be sort of an extension of part of what Karim talked about. We're talking about the extremes of left heart hypoplasia. So the patients that have such severe left heart hypoplasia that we're worried that might evolve into hypoplastic left heart syndrome. And I think in a lot of papers, these get clumped together. And I really just want to make sure we delineate the phenotypes because there's really different predictors of outcomes and different fetal interventions offered. So just as my disclosure, I am an advisor for A2 Biopharma. So we're going to basically talk about the patterns of the fetal borderline left heart. We're going to discuss published literature and new work on predicting outcomes. And if time permits, we'll talk about fetal interventions for borderline left heart phenotypes. So there are basically two borderline left heart phenotypes. So there's, of course, what we call the long skinny phenotype, or the left heart hypoplasia is what we call it, LHH at our hospital, which is very much what Karim just talked about. This is the coarctation phenotype. It's the long skinny left ventricle, but sometimes it's so thin that the left heart still is insufficient to support systemic circulation. So a Norwood or stage 1 palliation is needed. Then we have the left heart phenotype that starts as critical aortic stenosis. And this is the rounder, boggier phenotype. And we'll go through ultrasounds in a minute. And then there's left ventricular growth arrest in utero. And when you're born, there's left heart hypoplasia. And we call this the short, fat left ventricle. So here's some ultrasounds. This is a fetal early aortic stenosis. So you can see that the left ventricle at this point is dilated. There's significant ventricular dysfunction. It is currently the same size as the right heart. We'll talk about that later. And we see this phenotype, which is the long skinny, which looks like a severe coarctation phenotype when you see it. And I'll tell you, we're a very busy fetal center. Both of these get called HLHS when we're referred to us. So, but they have really different pathways. Now, just to clarify, HLHS, this is more classic HLHS where you can't see the left heart, the left ventricle. There's usually severe mitral stenosis or mitral atresia and severe aortic stenosis or aortic atresia. But those other phenotypes are ones we're worried will, by the time birth comes, will evolve to HLHS and need to be treated as HLHS. So let's talk a little bit about the long skinny left ventricle. The thought of this physiology is that there's abnormal inflow to the left ventricle. So sort of no flow, no grow. And we know this because all the patterns that cause this pattern. So are all of the phenotypes that cause this pattern. So we know that if you have an abnormal atrial septal attachment, if the atrial septal attachment goes leftward, we're altering foramen valley flow and you get this long skinny phenotype. We know that if you have foramen valley hypoplasia or a small PFO, you get this phenotype. When there's normal ductus venosus flow, either from a congenital diaphragmatic hernia or other things that like omphalocele that alter ductus venosus flow, we get this long skinny phenotype. And in this example, with an LSVC to coronary sinus, we also get this phenotype. So we think that this long skinny phenotype here is due to abnormal inflow. Here's another example. This is kind of a late cause of this phenotype. This is when you have an atrial septal aneurysm. You can see this goes all the way over into the left ventricle and late in gestation blocks fetal blood flow. And you can actually get retrograde flow in the arch. And the thought is that this sort of, again, is blocking inflow. These are just some other examples of this long skinny phenotype. The same picture here, we can see you can get this severe phenotype where you have reverse flow in the aorta. This is where you actually have reverse flow across the foramen valley. We're having left to right flow across the foramen valley. And we're also having retrograde flow across the transverse arch in the 3 vessel and trachea view. So what about the short fat left ventricle? So this is almost always associated with aortic stenosis and endocardial fibroelastosis. So phenotypically, it looks very different. Usually you first see a dilated left ventricle, systolic and diastolic dysfunction, and then the LV just stops growing, the rest of the heart grows around it. We think this is an outflow problem or a myocardial problem. Something is happening with the aortic valve or something's happening with the myocardium. And we haven't figured it out yet, but the physiology seems quite different. So this is an example of a patient of ours at 23 weeks presents, and the left ventricle looks dilated. You can see that the left ventricle is larger than the right ventricle. There's severe systolic dysfunction. I'm not showing the valve, but there is valve stenosis. When we see that child only 4 weeks later, now the left ventricle is on top in this image, you can see the left ventricle is the same to a little smaller than the right ventricle. And now there's significant endocardial fibroelastosis. There's continued dysfunction. And when we look at birth, this is hypoplastic left heart syndrome. So this is a case where fetal aortic stenosis evolved into hypoplastic left heart syndrome. Now, the issue is both of these phenotypes can result in stage 1 palliation, and they sort of have a continuum of severity. So the long skinny left ventricle might just be a coarctation. They might get an arch repair via a thoracotomy. If it's more severe and there's transverse arch hypoplasia, they might get an arch repair via sternotomy. You might need a subaortic resection, maybe mitral valve intervention, maybe a Ross procedure with or without a CoAo, and in severe cases might need stage 1. The short fat LV, its most mild case, you might need an aortic valvuloplasty, may also need an arch intervention, might need an EFE resection, and then might also need mitral surgery, a Ross procedure, or a stage 1. So both of these can go down a similar pathway, but my sort of point of my argument is these parents need to be counseled really differently, even though they might go down the same path. So how do we predict biventricular versus single ventricle? So we all know this literature, it's very old. This is some of the first papers looking at critical aortic stenosis. This was a paper by Dr. McCaffrey and Sherman. This is one of the first ones really showing this, that they compared the biventricular patients with patients who ultimately were biventricular versus single ventricle or died postnatally, looking at these dots. And group 1 are the ones that had biventricular circulation, and group 2 are the ones that did not. And you can see that the group 2 had growth arrest of the left ventricle. So we know, again, that you have this arrest of aortic valve size, arrest of LV size. Sort of one of the best papers is a paper that's quite old now out of Boston Children's. They looked at the 43 fetuses with aortic stenosis diagnosed less than 30 weeks. And they looked at what variables were predicted with BIV versus single V. And 6 of them were BIV and 17 resulted in HLHS. And what they found, and I'll blow this up, is these 4 factors predicted outcome. And these now are the basis for fetal intervention, which I'll talk later. But this is retrograde flow in the thoracic aortic arch, and the transverse aortic arch, left to right flow across the foramen valley, monophasic mitral valve inflow, and moderate to severe LV dysfunction. So these factors are applied in critical AS. Unfortunately, some people have applied them in that long skinny LV and they just don't apply. Now, there have been a couple of papers. There have not been a ton of work done on this long skinny left ventricle, really looking at who's going to be a single ventricle. Now, this paper, Karim already discussed Dr. Hornberger's paper from 1995, and this is where she mixed patients with varying degrees of left-sided hypoplasia, including the coarctation left heart phenotype and the critical aortic stenosis phenotype, and put them into 3 groups: biventricular, stage 1, and aortic atrachas. And the aortic atrachas kind of got excluded ultimately. And she said, how do we predict who's gonna be a single ventricle versus who's gonna be a biventricular circulation? And ultimately their decision was, if there was poorer growth, they're more likely to be single ventricle. The problem with this approach, I mean, it's great, and many of us have used this paper, is that when you're seeing a patient in clinic, you don't know what the growth has been, and it's hard to consult them at that time. Now, if you're following them longitudinally, it's a little easier, but it's hard for the first or second visit to say, well, what path are you on? And so I think, there's been more work done since this time. This is another paper, and that Karim mentioned, mainly looking at coarctation. This was by Dr. Quartermain from 2009, but they did have, among their 31 fetuses, of which 17 needed a coarctation repair, 4 of them underwent single ventricle palliation. There wasn't a deep analysis because this is pretty small, but they did notice that all 4 had left to right flow at the foramen. So it was 100% sensitive, but certainly was not, or 100% specific, but certainly wasn't sensitive. So this is, again, you just saw this, this is discussed from the Quartermain paper, trying to predict what to do for coarctation. But again, there wasn't great recommendations on sort of what to do for those that might need single ventricle. How do we decide who's going to be coarc versus single ventricle? How do you tell these parents? And I think this could be important when you're talking about possible termination, possibly moving to near your hospital, a 6-month hospitalization versus a 2-month hospitalization versus a 3-week hospitalization. So how do we predict who's going to need a single ventricle repair? So this is probably the most comprehensive paper until one we just published, I'll discuss in a second. This is from the Stanford group, Dr. Edwards and Dr. Moscatia, and they looked at many, many, many factors. Again, they were comparing, it was a mixed group, so both long skinny left ventricle and short fat left ventricle. They put many, many factors in and came up with a bunch by univariable analysis that predicted single ventricle palliation. So this is a mixed group like Dr. Hornberger's, but really the outcome was single ventricle versus biventricular. And basically they had lots of predictors, but they said when they did stepwise logistic regression of multivariables, said the strongest independent variable was the RV to LV length ratio. So that's sort of discriminating the short ventricle, short fat from the long skinny left ventricle. So the shorter your ventricle, the more likely you were to be single V. An RV to LV length ratio greater than 1.28 predicted a single ventricle palliation with reasonable sensitivity and very good specificity. And left to right shunting at the foramen valley also predicted single ventricle palliation. So this is an area we've been really interested in. So this was a paper we presented last year by one of our fellows, Dr. Bernardos. And what we did is we actually looked at the trajectory of fetal aortic stenosis versus fetal left heart hypoplasia. So these are two graphs. This is looking at the aortic annulus raw data, and this is looking at the Z-score. And what we showed is that the slope of growth, if you're, and this is intuitive, but hadn't been shown, if you have critical aortic stenosis, the aortic annulus grows, but very slowly. If you have this long skinny phenotype, the aortic annulus grows at almost double the rate. And if the Z-score drops in critical aortic stenosis and pretty much stays flat. And the reason this matters is most of these algorithms use Z-scores, but our point is Z-scores change differently based on what phenotype. So you can't put both critical aortic stenosis and left heart hypoplasia in the same models because these Z-scores act differently over the course of time. So if you're looking at someone at 24 weeks versus 30 weeks, it really has a different meaning because the growth is different. This was just, this is a comparison in that same paper of 10 patients that started with the exact same Z-scores, whether they had critical AS or left heart hypoplasia. And you can see that the Z-scores plummeted in the aortic stenosis group while they stayed the same in the left heart hypoplasia group. So then we looked and said, well, let's just look at what happened with these outcomes. So this paper had 54 fetuses, including one fetal demise. So of the 53 live births, there were 20 with fetal aortic stenosis and 30 with left heart hypoplasia. So in the aortic stenosis group, 75% went to have single ventricle palliation, 15 died prior to intervention, 15%, and only 10% of this AS group had a biventricular repair. We excluded fetal interventions for this, by the way. Of the left heart hypoplasia, however, 88% had a biventricular repair or no surgery at all, and only 9% had a single ventricle palliation. So these pathways are really different. Again, just highlighting how different the counseling needs to be. So, and this is just showing it in pie graph format. If we look at single ventricle palliation, it's much more likely when you have critical aortic stenosis than this long skinny, even when the long skinny is severe. This only included severe left heart hypoplasia in which there was reversal of flow at the foramen of LA and reversal of flow in the arch. So it didn't include any mild coarctation patients. So this paper just came out a couple of weeks ago. This is from our group 2. And we actually said, well, what predictors do predict outcome when we're limiting to this left? So we also looked at lots of factors. So we actually split it by gestational age band. So I'm just showing you the 32-week band. So similar to the Stanford paper, we looked at lots and lots of factors and found that lots of factors were associated. And we looked at no surgery versus 2 ventricular surgery, which is coarct repair, versus single ventricle surgery. And, you know, we found lots of things were significant. The most significant was foramen of LA direction. If you had any left to right, you were much more likely to need single ventricle surgery. However, what we realized is there were lots of interactions in this and it became complex. So if you had a very small mitral valve, it may not be as important if you had a small arch. If you have a very small arch, it may not be as important if you had a small aorta. And so we decided to change the analysis from this very traditional, let's find, univariate multivariable analysis to something called a CART model, which is a machine learning model. And so, one of the interactions we noticed was gestational age. So the PFO flow really mattered by gestational age. So instead we did a CART model. So what this does is you put all the variables in and it divides it by sort of most important nodes using machine learning concept. And we thought this was much more helpful. And let me just guide you through this. So this is looking just at our 32-week band. We looked at all studies. So these are all severe left heart, or these are all left heart hypoplasia of any kind in his paper. So we had mild, moderate, severe, but you had to have something less than -2 Z-scores. And basically, so you could take a patient and you say, okay, my patient has right to left flow across the foramen. They have a long skinny left ventricle, but they have right to left flow. So just based on that, 81% are going to need no surgery. 19% are need BIV. This was almost always an arch surgery. And nobody at 32 weeks with right to left flow with the foramen needed a stage 1 palliation. Great. That's really good news. And if you look through here, we looked at, this is the aorta pulmonary ratio. So if the aorta pulmonary ratio is greater than 0.76, none of the fetuses needed surgery, period. And if they had a lower aorta pulmonary ratio, about 27% needed biventricular surgery. And then we could look at the transverse arch Z-score. And you could split by how small, if the transverse arch Z-score was hypoplastic, in addition to having a small AP ratio, then it was about 50-50, whether they're going to be none versus coarctation surgery. Now, if we look at the other end of the spectrum, okay, well, I have a fetus, the left heart's really small, and there's left to right shunting. just based on the left to right shunting after 32 weeks, we can see that 50% needed a single ventricle repair. That's quite high. So then we can look and say, okay, well, but the mitral valve Z-score is also small. It's less than negative 3.6. Now we're up to 70% needing a stage 1 surgery. And so just want, you could continue to walk through it, but we just published this and did it in gestational age bands. And for us, this is sort of easier because it builds in all those different interactions together, including gestational age and the different Z-scores. So what about fetal intervention for these? So we mostly know about aortic valvuloplasty, but I'm also going to talk about maternal hyperoxygenation. So we know that fetal cardiac intervention is either a pharmacologic or surgical manipulation of a fetus in order to improve fetal cardiac status. It inherently involves some risk to the mother. So just to put in a plug, for those of you who don't know, there is this wonderful organization run by Needham and Grady at UCSF, the International Fetal Cardiac Intervention Registry, to which we belong with this little Houston heart right here. But please join it, and there's multiple great papers coming out from this organization. So I'm going to talk briefly about aortic valvuloplasty and updated numbers. So the goals for fetal aortic valvuloplasty are not to improve survival, but to increase the likelihood of biventricular repair, to improve flow to the fetal brain, and to improve long-term outcomes, because the thought is that if we have 2 ventricles, that's better than 1. And we know that a cannula is inserted through the maternal abdomen, through the uterus, through the left ventricular apex, and then a balloon is inserted across the aortic valve. And the goal is then to improve antegrade flow. So this is an intervention that we have done. So you can see here, and you've probably seen these by other organizations, including Dr. Turetsky, but here's our left ventricle here. Here's the needle coming in. We're going through the chest wall right now. We'd already gone through the uterus. So you can see the needle now is the tip is in the left ventricle. So once we get the tip placed nicely in the left ventricle, we'll put a wire out, and the goal, you'll see the wire come out. The goal is to get the wire across. Here's the hypoplastic aortic valve annulus here. The goal is to get the wire across the aortic annulus, which you'll see come out in just a second. Sometimes it flips into the mitral valve here. Here's our wire. We're flipping it. It's going to go across the aortic annulus, and we place it up into the ascending aorta to get some anchorage. And you'll see then we'll push a balloon that looks kind of like this over the wire. And you'll see it's a little hard to see it coming out. You'll see it come out in a minute, and we'll see it blow up and inflate. And we basically inflate that one, there it goes inflating 1 to 3 times to sort of tear those valve leaflets open. This is almost always a unicuspid or bicuspid aortic valve. And the goal is to improve flow. So you can see this is our patient who had retrograde flow in the arch afterwards. Now they have prograde flow in the arch. This was this patient at birth. So we stopped LV growth arrest, although you can see there's still some left ventricular endocardiofibroelastosis. There's definitely diastolic dysfunction. And this is at about 9 months of life. So you can see we have preserved the LV size, although there definitely is diastolic dysfunction, and there is absolutely mitral valve abnormalities, and this child needed a mitral valve repair. And now that child is 4 years old and has had a mitral valve replacement. So how are these outcomes? So this is a paper from the International Fetal Cardiac Intervention Registry looking at 86 outcomes from all over the world. This was published in 2014, so it's a little old. And at that time, there was 17% fetal death of patients considered for valvuloplasty, 7% termination in pregnancy. Postnatal death was 21%, and 29% of them were becoming biventricular. Now, this is a really beautiful meta-analysis that just got published. It's not even in its final form yet. And they took the Boston, well, a lot of us know there's a lot of Boston data out there, plus the international, plus the raw data from some of the international sites, and sort of did a meta-analysis. Now, just so you're clear, the way they've done this table only looks at technically successful. So you can look at this 2 ways. You could look at intervention to treat. We're going to take everyone who got considered for fetal intervention, or we could just take the ones that were technically successful. And so this is kind of, you're always looking at the best if you're looking at technically successful. So in the technically successful group, 52% were biventricular. If we look at the live-born group, so this includes it excludes the ones who had a fetal death. It includes the ones who had intervention, but it was not technically successful. So if you go in this group, they had 46% were biventricular. So not that different than 52, although 10% did have late death although this does not comment on late death. And certainly because of the diastolic dysfunction, you can have late death in this group too. And the conclusion of that paper, and definitely our conclusion, is that the jury's still out. It definitely improves likelihood to biventricular circulation, but whether it improves long-term outcomes, I think it still remains to be said. So for the last few minutes, I'm just going to talk about maternal hyperoxygenation, and this is for the other phenotype, for the long, skinny phenotype. So this is a beautiful paper by Dr. Reichik's group out of CHOP that showed several years ago that when you give hyperoxygenation in left heart hypoplasia, this was a severe left heart hypoplasia with retrograde flow in the arch, that when you give oxygen, you can, sorry, this was an atrial septal aneurysm, not severe left heart hypoplasia, but when you give oxygen, it fills the left side and you can get prograde flow in the arch. And so this is their paper. They looked at 16 studies, 16 patients who had an aneurysm of atrial septum, and they did hyperoxygenation for all of them, or for 12 of them, and 2 postnatally had developed coarctation. So we said, well, let's see if we could do this chronically. Do we think that if you give oxygen and can improve flow across the aorta, if you give oxygen all of the 3rd trimester and we're consistently increasing flow across the arch, could we actually grow the arch and prevent further surgeries or improve growth of the left heart structure? So this was a pilot study published in 2015. We had 9 mothers and had 9 historical controls. And we gave maternal hyperoxygen therapy through a non-rebreather, a minimum of 8 hours a day for the 3rd trimester. And our outcome variables rate of aortic growth and mitral growth. So of note, these are our 9 patients. This is the acute testing. We looked at ascending flow, ascending aortic flow without oxygen and with oxygen. And you can see that every single one was a responder and had increase in acute aortic flow calculated by Doppler with administration of oxygen in an acute setting. And these were our results. So on the left, this is aortic annulus, and this is all comers, and these are patients who were compliant because some did less than 8 hours a day. So this is each patient, and this is the mean. And if you look at the red are the ones on oxygen, and the blue are the ones not on oxygen. And we saw a non-significant but a difference in those that were on oxygen versus not. They had a slightly larger aortic annulus. When we limited it to the moms that did 8 hours a day, which was about half of our group, the rest were non-compliant, we did see a significant difference between the aortic annulus in oxygen and not on oxygen, but it was subtle. It was about just less than a 1 millimeter difference. So the question is that clinically important or not? So when we look at the overall outcomes, they weren't that different. When we looked at our intervention group, 7 of them only had an arch repair, 2 had a single ventricle palliation. In the control group, even though only 1 had a single ventricle palliation, they had many more complex patients. So patients that had to go an arch and a mitral valve repair. This was a complex patient who, one of these patients had a complex repair and ultimately died. So it could be argued this group was a little more severe, but maybe by 1 person. So some subtle changes. So we did a secondary analysis and we thought, well, if we're improving oxygen to the fetal brain, maybe we can improve fetal brain size in our group too. So we did a sub-analysis, our secondary analysis, looking at fetal brain size over time. So this is fetal head circumference, and this is fetal bipyramidal diameter. And the red group is oxygen therapy and the blue group is not. And what we were really surprised to find is that the oxygen group actually had slower brain growth. That was not significant when we used head circumference, but when we used bipyramidal diameter, it was significant. It was really hard to explain. We don't know if giving oxygen is impairing placental circulation, so we're overall making the baby smaller. It's been hard to repeat, but this definitely caused some caution, I think, in the fetal hyperoxygenation space. We're still studying this, but with very close monitoring of fetal brain size for parents that do participate. So of note, this is a study done out of China that was very similar to ours. They looked in patients with severe coarctation and they gave sustained maternal hyperoxygenation in a very similar method to ours. Now they had dramatically different results, more optimistic results than we had. I mentioned we had a subtle change. These are all different left heart structures. This is mitral valve Z-score, aortic valve Z-score, isthmus, and ascending aorta. The blues are the controls, the yellows are the non-intervention, and the purple are the intervention. And you can see that they universally demonstrated or published growth in every patient that got maternal hyperoxygenation, and it was near normal for all the patients. So these were much more optimistic than we got. We certainly didn't see results like this, but this paper is out there. So basically, in summary, the natural history of growth of the left-sided structures in borderline left hearts really varies based on phenotype. Left-sided structures grow throughout gestation at a faster rate in those with left heart hypoplasia than in aortic stenosis. And the influence of Z-scores, if you're using them to make predictions, really varies by phenotype and gestational age. Left heart fetuses with left heart hypoplasia should be counseled differently than aortic stenosis, as most will have a biventricular repair compared to those with aortic stenosis unless they undergo intervention. And in left heart hypoplasia, patent femoral flow is the most consistent negative predictor of single ventricle palliation. So if you have right to left flow, they will not be a single ventricle. And that is all I have to say. I look forward to questions if we have time. And this is just a thank you to our team.
Thank you so much, Shane. Beautiful talk and very, very important different points to discuss. But Karim, are you still there?
Hi, Rima. Yes, I'm here.
Yeah, thank you so much. I mean, we'll probably open the floor for discussion now, and we have like 5 to 10 minutes. I don't see questions here. I see only one from Anna Seal saying, of the 14 patients, that's for Shane. Of the 14 patients with left to right flow at the foramen ovale, who had single ventricle palliation, did they have forward flow around the aortic arch at that time, she means?
Oh, let me share my slide again. I can show you that because I went through it rather quickly. Most of them had retrograde flow, but not all of them. Let me just show, I think it's easier to show it on the slide if that's okay. Let me just go back, sorry. It's on this slide here. So if you look here, so this is our single ventricle surgery. And if we look at aortic, I took it off here to shorten the slide. We do, on the actual published paper, we have antegrade arch flow. And I think 2 of the 8 still had some antegrade arch flow and 6 of the 8 did not at 32 weeks. I think ultimately it would have been reversed, but we're not looking at everyone at 35 weeks.
So what's the message here?
So, Shane. I mean, I think arch flow, certainly if you have retrograde arch flow and foramen flow, that's helpful in predicting single ventricle, but plenty of patients who had both of those were not single ventricle. So I think, it basically right to left flow is a good negative predictor, but we don't have great positive predictors. I think if you have left to right flow, your risk is much higher of needing single ventricle repair, but then you sort of need to look at mitral valve flow and other flows, but we can just say your risk is higher. There's no definitive you will be a single ventricle. Also depends on your institution.
I like what you said regarding the fat ventricle and the slim ventricle. So, if we want to choose, then we choose to have the slim ventricle, the slim LV, right? That's right.
And the thought is that because, if you fill that left ventricle postnatally as the RV pressure drops, it has the ability to grow, right? But we're always telling our surgeons, be patient. Don't try to make a decision at day 1 because the LV will fill. But if you have a short, fat, stuck left ventricle, that's never going to grow. Like there's no capacitance for it to grow because it's stuck, it's short, it's not going to lengthen. But those skinny ones can definitely fill as RV pressure drops and as you improve filling with pulmonary blood flow.
Karim, do you agree to that? It's better to have a slim, long LV rather than chubby, rounded LV in cases of predictors of biventricular to univentricular repair?
Yeah, I think, what Shane has provided, and sorry, I missed a bunch of the slides, but I think I agree with her point there. I think, the skinny tends to have a better outcome, better function than the really very global LV that many times ends up with very poor function as well.
But then we will have the mitral valve to tricuspid valve ratio and the aorta to pulmonary valve ratio out of the equation here, right?
Well, it depends. If we use it in our CART model, it would sort of depend which path you're on. You can definitely use those other ones, but we kept finding ourselves that in all these if-then situations. So we, have moved towards using something like CART modeling, but I think sometimes people you do both. We'll say, what would this model say using these? And what would this model say? And if they agree, it's easy. If they don't agree, then.
Your model is very logical. Going to the maternal hyperoxygenation test, I have a feeling that 8 hours is too much. I don't know, Karim, what do you think? I mean, 8 hours.
Honestly, I have not used it, at least in the centers where I've been. So I'm curious. I'm still very curious about this, but Shane can maybe shed more light into it.
Yeah, I can comment. So, 8 hours with a non-rebreather mask was hard, and only half our mothers were compliant. Now, what's interesting is the moms that did it longer had better outcomes, had bigger aortas. And so, but we know that we can't ask someone to be on a non-rebreather 24 hours a day. So the way the trial currently is we actually put them on nasal cannula, so less dense, less oxygen, but for 24 hours a day. Well, except showering and cooking. But we have them sleep with it, we have them wear it, but it's only 4 liters. And so we're seeing if that has the same effect. But our numbers are way down because we published the neuro paper, and we have to counsel everyone that there might be neuro effects. People are much more likely to enroll in the study.
I think
but now we're doing brain MRIs on everybody.
It's not natural. I think I'm just being philosophical here. I don't think it's natural. I don't think you can. I wonder where when we did the hyperorganization with Dr. Huta, he used to say 4 hours. That's for to decrease the pulmonary vascular resistance, but I don't know where the 8 came from. And I think personally that with time there will be damage to the structures. It's not natural. Yeah. Some structures will not benefit. We might get the aorta, but not the brain. Yeah.
We didn't see any yet. Well, we don't know. I mean, developmentally, those groups are the same now. When we look at long-term development, the 8 hours was from Dr. Cole in Germany, who did the first sustained hyperoxygen study. So that's where we got the 8 hours a day. But we also, one of our thoughts was that maybe the off on, because people would do it for 2 hours at a time or 3 hours at a time, was actually hard on the fetus. And if you had a sustained intake of oxygen, it might be better, but we're still trying to figure it out.
Someone, Nabil is asking if the hyperoxygenation test on a pregnant mother, what would be the effect on the PDA of the fetus?
So this is a wonderful question. We were very worried about it in the beginning. So for the first 9 mothers, we had them come at day 1, 2, 3, 5, and then once a week, the whole 10 weeks, the rest of the pregnancy. And we never saw any effects on the PDA. So in the current protocol, they just come twice the first week, and then they come every 3 weeks. And I think obviously oxygen can close a PDA in a fetus without heart disease, but I think these PDAs are so large and all your blood flows going through them, or the majority, at least, all of our patients were 30% to the aorta or less. I think it's just so large that it just won't close.
Beautiful. Simona, she has a question. She's on the panels, but I just want to say, she's asking, Simona from Italy, is the same mother, did you perform hyperoxygenation more than once before birth? Do you think that the fetal postnatal outcome would be better if you perform this test in an earlier gestation age and more than once? Thanks.
Sure. So the difference, there's 2 kinds of maternal hyperoxygenation. There's diagnostic testing, which a lot of people are using to sort of mimic postnatal physiology. And then there's chronic therapy. So we use it as chronic therapy. So we started it at 26 weeks and gave it every single day until delivery. So we definitely did more than once. It was daily until delivery. Now we started at 26 weeks based on Rossinen's paper back from the 90s that said that's when pulmonary vascular resistance drops in fetuses, and that they're not responsive to oxygen. Before that, that's both what the animal studies say for 3rd trimester and the human studies say. And we did have one mom we tried to enroll at 25 weeks, and she was not reactive. She did not have increased flow with oxygen. And we brought her back a week and a half later, and she was responsive. So we just do it in the 3rd trimester based on prior work that's when they have more reactivity.
So 3rd trimester till delivery, right? Is this simple? Thank you so much, Shane. Beautiful talk. Kareem, what is the message from, you put at the take-home message, you sort of modified can you please go back to the last slide you showed, because this is very important. It sort of summarizes many papers and many advices regarding which ones to choose to follow if you want to diagnose coarctation. Hypoplasia of the arch is not a difficult issue. We're talking about the discrete coarctation where you could miss, and the miss rate is very high.
Right. I think I
know that you're in the clinic and know that there are patients outside. Yeah.
Right. Let me share this first, and then again, the importance of this is we haven't really had really great prenatal detection rates with not the either side of the spectrum, where it's clearly normal, clearly abnormal. I think these are the values from the various studies There was a meta-analysis that was published. I didn't include it just for the sake of time, just went over all these articles that I kind of shared. In general, they didn't really specify the specific cutoff values for each, but in general, this is really what has been kind of commonly cited. It varies slightly. As I mentioned, some studies look at later gestational age, second trimester, third trimester, but I think in general, these tend to be reasonable cutoff numbers. I don't know, Shane can comment if she uses different cutoff values. I think 0.6 kind of tends to be a common cutoff value for 4-chamber to left-sided versus right-sided sizes. The Z-score of -2 of the aortic arch. The isthmus, as I mentioned, I think isthmus to ductus ratio seems to be an interesting ratio. I still look at doing some more use of this new formula that the group in Sweden came up with. It seems very interesting from their case study with 65 fetuses. It was quite sensitive and very specific. It's not that hard to get. I think it's already included in the 3-vessel view. So I think that really maybe can help. I think really we still have ways to go. I mean, most of the places we have detection rate of prenatal coarc. Again, we're not talking about the clearly hypoplastic left heart syndrome, etc., with severe arch hypoplasia. But we have ways to go from like 20-25% detection rate to something way better. Even after the AIUM changed the guidelines and getting the outflow views, etc. Some of these studies, I must say, some of the data, even in the studies that compiled the data over the years, of course, they include studies done before 2013. So it'll be interesting to see a little bit later studies that come up and look at the prenatal detection rate after that, after those guidelines started to be followed. But still, I haven't seen really very exciting prenatal detection rates, except in France, really. So this is really what I shared here, and I think probably you might have referred to the algorithm from Quartermain just to make it easy for what to plan during prenatally and what to do postnatally with these numbers. I think even again this is a little bit modified from the paper from Quartermain, which was published several years ago. But basically, even if you're not able to see the arch, but you have some right and left sided discrepancy, that's important really to look into it. Or you're not even able to see the arch completely. You either bring these patients back, or at least make sure to get some of the basic numbers that you can get from the 4-chamber view and the 3-vessel view. If everything looks normal, really have very low suspicion, I think it's fair to do a postnatal critical congenital heart disease screening test with a pulse oximetry, and then decide really if these babies need to have an echocardiogram or not. The other question that kind of comes in as well is, are they okay to deliver not at a tertiary care center? And we have referrals from places that are really far for the family to drive and come and deliver if they go into labor, and that becomes even more important when some of the values are abnormal. So that's why it's important to do serial follow-ups and measure these ratios. I think the major ones I listed on the slides, and till later in the 3rd trimester to make a decision. Are they okay to deliver at an outside hospital? Do they really need to deliver whereby they're going to get an echocardiogram in the first few hours or not? I think if they're quite abnormal, it's important to start prostings and get an echo soon. If they are if they're normalized, I think it's still important to get an echo postnatally, but I don't think it's essential to have the family change their delivery plans if that is being planned at a non-tertiary care center, and or there is no need to admit the baby to the NICU and start prostin infusion, etc. So this is kind of really the take-home message from that.
I was just going to say, I don't know if you saw there's a recent really nice paper from Bana Ira in the US, who showed that she did a cost effectiveness analysis to see what was the best strategy, because these are always so challenging. And I'll say, from a fetal cardiologist, we overcall these all the time because we're so worried something's going to happen. So I'd say, at least 6 out of 10 that we say are worried about the arch, they're not. And so she showed basically that it was more cost effective to see these patients once fetally, and if you think there could be a coarct, to do a postnatal echo, because when we serially follow them, we almost never decide not to do a postnatal echo. We're never comforted by, or rarely comforted by, serial echoes. We only get more worried. And so that if you think that there's going to be a postnatal coarct, just to plan on a postnatal echo and to minimize the additional fetal echocardiograms. In her model, it was best to only see them once in fetal life. We all argued that, like, we can't only see them once. We need to see them once at near delivery just to counsel them. But it was a really interesting analysis. And I know we've pushed a little more towards trying to reduce the number of fetal echoes on these patients, because it's true. It almost always is still equivocal in the 3rd trimester.
I don't quite agree, Shane. This is because we have people from all over the world watching this series, and they're underdeveloped, more developed, equal developed countries, whatever you call them. So I would say that being on the cautious side is better rather than being cost effective. I wonder, like, of course, in the US, you can get the service, but supposedly you don't know where the mother is going to deliver. And you're not sure of that this is, and it happens a lot. I had 2 weeks back a case where just diagnosed at 37 weeks hypoplastic arch, and the question that was like something new to the obstetrician, and where is she going to deliver? She needs a cardiac center, she needs a tertiary care, and all that. So, Kareem, would you agree to be on the cautious side rather than being on the cost-effective side?
Of course, we don't want to miss a coarct patient. So of course, we tend to err always on the
depending on the country, I would agree.
And this would be extremely cautious, though, right? This is saying universally do a postnatal echo. So it's like overly cautious is what I'm suggesting.
Because counseling parents is very important. If you tell them, I suspect coarctation, and there is no coarctation postnatal, they'll be very happy afterwards. But of course, they will live the stress. But if you tell them there is nothing, and then they turn out to be a coarctation, and which is duct dependent, the baby went home and came back in shock, I think we have to, and this is why I felt that this talk is very important worldwide. And I know that most speakers here are very, very eminent and expert in their fields, but we have people who do fetal echo in different countries that they need the advice about coarctation. And we always say it's difficult to detect antenatally, but the message here is to go for the ratios of the ventricles. And as Lisa said many years back in the 90s, the ratio is very important, but up to 34 weeks, right? After 30 weeks, sensitivity decreased a lot. The ratio of the mitral to the tricuspid, the ratio of the aorta to the pulmonary, and all that. But if you have any suspicion, bring them back and let them deliver in a place where you can see them. Do you agree to that?
Yeah, I agree. I think, as long as these numbers are not, quite obviously abnormal.
Yeah, that's the difference. We're talking about borderline cases where you were worried.
Really borderline, not really that concerning, but you can't really rule it out completely. And you do a postnatal pulse oximetry screen, and, everything passes. I think it's reasonable.
But a moderate coarct might be missed on a pulse oximetry. You have to also do functional blood pressures, right?
And if the PDA
they're not always that hypoxemic.
Yeah, I don't believe in that. Yeah. Pulse oximetry can miss. Also, I've learned something from Lisa, and I think there's a paper coming out. Months after the coarctation was the asymmetry of the ventricle diagnosed in utero, the baby developed coarctation. So, I think it's better to bring them back if you are at minimum suspicion, or tell the pediatric cardiologist in the area that you have to keep on looking at the manual pressures, upper and lower limbs, get the difference. And if you have a suspicion, refer them to the pediatric cardiology clinic. Mm-hmm. Thank you so much. We're getting so late. And thanks again. Thanks for coming, and thanks for teaching the whole world through the Congenital Heart Academy. to our colleagues, and you can always watch the series at the YouTube under Fetal Cardiology Congenital Heart Academy. And we're very happy if you would like to write to us to say what topics you want us to discuss. Have a good day. Thanks, Shane, thanks, Kareem. And I'd like to thank Grace and everybody who had to leave early. Thank you.
Thank you, Rima.
Thank you so much for the opportunity.
Good to see you. Good to see you, Shane, too.
Bye.
All right, thanks, bye guys.
Bye-bye.